Thank you very much. Good afternoon. Thank you so much for having me present this webinar today for WADM. As Wendy said, my name is Sue Ann Bell, and I'm an assistant professor at the University of Michigan School of Nursing. I have no disclosures, and I'm grateful to the NIH, and more specifically, the National Institute on Aging, for my recently funded K23 award. This grant is one of relatively few focusing specifically on disasters that the NIH has funded recently. I hope this signals a shift in thinking in terms of recognizing that as the impact of climate change continues to increase, we must have a scientific understanding of disasters that comes from sound data and methodology. The lack of funding support has hampered disaster research, and this must change. To introduce myself and my work, I study the long-term effects of disasters on health with a focus on older adults. A fundamental premise of my work is to use novel methods to understand how disasters affect health outside of the usual focus on acute injuries, with the ultimate goal of building a better and stronger disaster response, one that takes these long-term effects into account. In my current work, and in the specific aims I've outlined above, I'm working to identify and address how older adults who have been hospitalized with chronic disease after a disaster have been influenced by various individual and community factors. The goal of this work is to promote ways that older adults can maintain independence after living through a disaster, as well as to avoid preventable hospitalizations. I'm also a clinician scientist, and my ongoing work in disaster response closely informs my research. Most recently, I was deployed for 6 weeks through the United States National Disaster Medical System, where I practice as a family nurse practitioner. The blue arrow in the picture on the left is pointing to me, shortly before landing in South Florida, just prior to Hurricane Irma. I spent 2 weeks in South Florida supporting overwhelmed emergency departments, and just as that response work was winding down, I was deployed directly to Puerto Rico, where I spent over a month staffing first a federal medical station and later supporting the US Navy's hospital ship, the Comfort. Disasters in themselves are not natural. Hazards such as hurricanes, wildfires, and tornadoes are naturally occurring, but the impact that they have on societies is largely human-made. Characterizing disasters as natural implies that we can't do anything about them, when really we can. Consider the difference between this picture of the flooded Amazon River basin compared to the lower Ninth Ward after Hurricane Katrina, an area that already doesn't look much like the rest of America. The effect of the hurricane crippled the already suspect infrastructure in New Orleans and undoubtedly cost many lives. Hurricane Katrina struck New Orleans over 13 years ago, but we have not advanced very far in terms of a scientific understanding of how disasters affect health, especially considering the recent controversy surrounding the research estimating the number of deaths attributed to Hurricane Maria. The public and the media perception of disasters has promoted the idea that disasters are short, self-limited events. This is perpetuated by huge media attention that quickly drops off after the first few days or weeks. But in reality, communities take months or years to recover. These long-lasting effects are not well understood. Changing these long-standing norms that disasters are limited and discrete events is an important goal of disaster research. But also, in thinking about the public perception of a disaster, there are many other types of disasters other than the tornado pictured here, ones that do not fit the traditional media idea of a disaster, but ones that can deeply affect communities. The recent white supremacist riots in Charlottesville, Virginia, could also be characterized as a disaster, as the mental health effects of this one event on this community will likely have enduring consequences that surely warrant study. Let's talk for a minute about the economic impact of disasters. Disasters are expensive, hugely expensive. 2017 was a historic year of weather and climate disasters in the United States, with over 16 separate billion-dollar disaster events. Costs exceeded $300 billion in 2017 alone. Hurricane Florence is projected at $50 billion. While we won't know the true cost of Hurricane Michael for some time, but it will likely be even more devastating than Florence. One thing we do know is that populations who are already marginalized are most affected by disasters. Racial and ethnic minorities, those living in poverty, individuals with disabilities, and of course, older adults. For example, during Hurricane Katrina, 60% of deaths were among adults aged 65 and older, and more older adults died after Hurricane Katrina and in the year after the storm than in any other group. During Hurricane Sandy in 2012, over 31 nursing homes closed, resulting in 4,500 older adult residents needing evacuation. And just last year in South Florida, after Hurricane Irma, 12 nursing home residents died when indoor temperatures reached almost 100 degrees Fahrenheit, despite being located just a short distance from a hospital. So in this picture, Nurse Mary Jo D'Amico is in Hurricane Katrina waiting for evacuation, which took several days. For those of you interested in learning more about Nurse D'Amico and the tragedy that took place at Memorial Hospital, the book 5 Days at Memorial by Pulitzer Prize-winning author Sherry Fink is an excellent read. The International Federation of the Red Cross and Red Crescent defines a disaster as when a vulnerability plus a hazard combine to exceed community resources. For older adults, there are many other factors that play into the standard definition of disaster and cause them to be at greater risk for health issues. Multiple chronic diseases, which affect almost 80% of older Americans, frailty and risk for falls, social isolation, and cognitive impairments such as dementia. Taking into account these factors in the definition of disaster, when communities are disrupted, so are supports for older adults and normal patterns of functioning. Multiple services that benefit older adults who are isolated, those that create a social safety net, are disrupted after a disaster. Meals on Wheels services and Elder Day programs are examples. Primary care providers, outpatient health services, and dialysis centers may experience closures as well. The loss of basic infrastructure, such as loss of power and public transportation, may cause interruption of chronic disease care, like access to dialysis. All of these examples can have long-lasting impacts. I approach my research using a theoretical basis, and in the conceptual model pictured here, I've combined two important models, the disaster management cycle and the social ecological model. I use this combined framework to organize my research into a series of steps. In this model, individuals function at the center, but are influenced at all levels by interpersonal factors, meaning family, friends, and peers, the individual's community, society as a whole, and policies that affect all of these levels. And within this, each of these levels is affected differently, depending on where we are in the continuous disaster management cycle of mitigation, preparedness, response, and recovery. There are numerous challenges in conducting disaster research. I recently read a great book called The Ostrich Paradox by authors at the highly respected Wharton School of Business who focus on risk management. I took their quote, "We fail to evacuate when advised. We rebuild in flood zones. We don't wear helmets. We fail to purchase insurance. We would rather avoid the risk of crying wolf than sound an alarm." and I added my own spin. We don't conduct data-driven research to understand the effects of disasters on population health. In 2015, the National Academy of Science and Medicine published a report focusing on building resilient communities after a disaster. This report called urgently for research identifying gaps in both patient and healthcare systems that occurred during the response period. Current policy, funding trends, and governmental activities focus on responding to disasters rather than being adequately prepared, and seem to go on in a cyclical nature where funding and policy attention are huge after a disaster, then trail off during quiet periods. Funders, such as the NIH, have made calls for researchers to capitalize on existing data when studying disasters. In my work, I look for ways to understand the health effects of a disaster on older adults by using these large, nationally representative data sets, which are often publicly available. In the rest of this webinar today, I'll discuss 3 recent studies where I have used these large data sets, such as Medicare data and cancer registry data, and connected them to disaster exposures to answer critical research questions. In this first study, we wanted to characterize 30-day hospital admissions after one major disaster. This study was intended to be pilot work, or in other words, a test of concept to test our hypothesis that they did increase for any cause. Our research question was specifically, do hospital admissions for any reason increase after disaster in the 30-day period? Answering this question helped us think about what are the impacts of disaster on older adults outside of the initial shock of the disaster, and to consider what are the enduring health consequences older adults face. Our study was set in the southeastern United States, which had experienced a series of strong storms and tornadoes over a short period of time in 2011. The 2011 Superstorm was one of the deadliest tornado outbreaks ever recorded, with over 360 tornadoes recorded during a 3-day period and 348 confirmed fatalities. Why did we pick this particular storm or this particular disaster? We used data from the Centers for Medicare and Medicaid Services. And in the United States, Medicare is a single-payer national health insurance program. Obtaining Medicare data can be a challenging process. We were able to piggyback on an existing study already using this data to study a non-disaster related issue. And through that data use agreement, we were given access to a few specific years of data only. So our challenge was to find a significant disaster that occurred at a time point that we could operationalize in our study, and the Southeast Superstorms fit that criteria. As I mentioned, we used Medicare data, specifically Medicare Provider and Analysis Review, or MedPAR. These files contain inpatient hospital final action stay records for all Medicare beneficiaries. We compared the 30-day period after the disaster for admissions for any cause to admissions in the region for the rest of 2011. Our analysis, which was a self-controlled case series, used a time invariant model where the main focus was on time. And because of this, confounders are controlled for within our Poisson regression modeling. This means that the analysis was based on when the event happened. This time invariant model also allowed us to control for seasonal factors that might have accounted for excess hospitalizations, such as influenza. This paper was published online in mid-2017, well before Hurricane Maria, but similar analysis techniques were later used by other research teams to examine mortality after Hurricane Maria. Here I'm going to bore you a bit and show you exactly what we found. With a sample of almost 30,000 individuals, hospitalizations increased by 4% in the 30-day period after the storm than when compared to the rest of the year, a result that was statistically significant. We then excluded the first 3 days after the disaster, hypothesizing that those 3 days would account for admissions that were acutely storm-related, such as trauma and injuries. When excluding those 3 days, we still found that admissions increased by 4%, again, a number that was statistically relevant. When we looked at admissions by individual states, we found that Alabama, the state that had the strongest storm impact, had a 9% increase in admissions, again, a number that rose to significance. I've just told you about the statistically significant increase in hospital admissions for any cause after this one storm. But it's important to consider the clinical impact as well. This 4% increase in admissions might seem small, but it actually accounted for hundreds of extra admissions after just this one disaster. Considering that there were 137 federally declared disasters in the United States in 2017 alone, examining excess hospital admissions for other disasters seems a highly valuable area of study, one that can inform hospital preparedness planning. I have ongoing work in this area to study admissions in other disasters, as well as by specific chronic disease processes. The second study I'd like to talk about today is currently in press at Pre-Hospital and Disaster Medicine. The goal of this study was to examine the association between exposure to disaster and health risk behaviors among older adults. The concept of health risk behavior has been used to describe behaviors with potentially negative effects on health, such as substance use, risky driving, no seatbelt use, and poor eating habits, among others. We used as our data source the Health and Retirement Study. The HRS is a longitudinal household sample that conducts over 20,000 interviews every 2 years and has for over 25 years. Over 270,000 hours of interviews have been conducted, and there are over 2,500 peer-reviewed publications that have used the Health and Retirement Study, making it a well-respected data source for research on older adults. And in this study, we used freely available Federal Emergency Management Agency data, where we matched federally declared disaster events to reported health risk behaviors for older Americans. This sample included close to 21,000 individuals and almost 60,000 interviews. 1,451 unique disasters were declared in counties in which HRS respondents lived during the study period. And logistic regression was used to evaluate differences in our selected outcomes by physical activity, change in weight, and smoking status by disaster exposure. We found that physical activity decreased in both adjusted and unadjusted analyses. Weight gain was seen as well in basic analyses and when controlling for a number of confounders. Both of these were statistically significant. We did not, however, find a signal when examining change in smoking, a finding that differs from past studies of substance use in individual disasters. This finding perhaps indicates that other habits and social conventions can limit the extent of damage to health behaviors after a disaster. To depict this visually, we found a greater risk of limited physical activity and of weight gain was associated with exposure to a disaster, leading us to the broader conclusion that the acute disruption of a disaster may adversely influence health behaviors and contribute to worse health among older adults. So in this third and final study, I'd like to talk about the recent results of an analysis my team and I did studying long-term cancer outcomes after Hurricane Katrina. Our goal was to look for associations between high-quality data sources in areas with significant disaster exposure. And in this analysis, we asked the question, did living through a disaster with a cancer diagnosis lead to earlier mortality? In order to do that, we selected 3 types of cancer that are among the most commonly diagnosed in the United States: breast, lung, and colorectal cancer. We used data from the National Cancer Institute's SEER Cancer Registry, which is arguably the best possible source of cancer data available. The SEER program collects and publishes cancer incidence and survival data from population-based cancer registries covering approximately 35% of the United States population. SEER has 19 separate population-based cancer registries across the US, including the Louisiana SEER registry that started in 2001. And it may be of interest and demonstrates the very significant impact that Katrina had that all cases diagnosed for the 6-month time period after Hurricane Katrina were excluded from the SEER registry. This gap in data collection is fairly unprecedented and will likely affect research among individuals living with cancer in Louisiana for some time. 15 parishes, which is the word that the state of Louisiana uses for counties, were most impacted by Hurricane Katrina, and these are the parishes that we included in our sample. Our final sample size was made up of individuals from one of these 15 parishes, plus a random sample from one or more of the other 18 SEER registries. The sample was limited to individuals who were diagnosed in the 6 months prior to the storm and who had complete follow-up case data. We used a 1-to-4 match of individuals from 2 groups, individuals in affected parishes versus a random sample of cancer cases from non-affected SEER registries. So, for each cancer case we identified in an affected county, we drew 4 random cases of the same cancer type with complete data from a non-affected registry, which we matched on the month of diagnosis and the type of cancer. In order to reduce heterogeneity, we removed cases from the comparison group if the individual resided in a county that experienced either a different hurricane or tropical storm at any time between 2003 to 2014. We did this by using Federal Emergency Management Agency data that includes national data on federally declared disasters and using county Federal Information Processing Standard Publication Codes, or FIPS codes. We used a time to event analysis, where our event was death, to examine the 10-year survival among our sample who were diagnosed in the 6 months prior to the storm. This Kaplan-Meier curve shows that more rapid mortality was seen in the disaster-exposed group, a statistic that rose to significance. This interso on the screen might not seem like much. But consider that 9 more disaster-affected deaths occurred per person years than in the comparison group of those who did not experience a disaster. Again, a positive association. Again, this is from just one disaster, so it's not generalizable across other disasters, but this data should make us stop and think that each disaster might come with its own adverse impacts on health. But this is a population and a location with many social inequalities, which are well documented to affect cancer progression, such as race, ethnicity, and poverty. And when we adjusted for these inequalities, we still found an 8% increase in mortality in our disaster-exposed group, an effect size that again rose to significance. In this study, we looked at just one part of the cancer control continuum, but there's a strong reason to think disasters have effects across all parts of it. And in that, many other factors play a role, with health disparities being a major example. Our next steps include exploring the effects of disaster across the entire spectrum of cancer care, and of course, to develop approaches to address the effects of disaster at every level. How can we do better? This study was not without limitations. It's observational in nature and studies only one disaster. There's a larger issue of imperfect data and imperfect measurement of disaster exposure. We know populations dispersed after Katrina, but where did they get treatment? How was it changed? And how much was it interrupted? However, in spite of these potential biases, our study still found significant impact, and again demonstrates the urgent need to change the focus of disaster response to extend beyond addressing immediate and acute care injuries and consider including a focus on long-term chronic health needs. So I'm getting towards the end, and I'd like to end with this quote and a pictorial example on the next slide. With a shared, healthy community vision, strategic planning that prioritizes health, and coordinated implementation, disaster recovery can result in communities that are healthier, more livable places for current and future generations to grow and thrive, communities that are better prepared for future adversities. As the severity and impact of weather and climate disasters increases due to the effects of climate change, preparedness is needed now more than ever. This is a picture of the only house left standing across a huge swath of beachfront homes in Mexico Beach in the Florida Panhandle, which is incidentally the region where I was born and raised. The owner of this home, Dr. LeBron Lackey, was quoted as saying he made small accommodations as he built the home, often, quote, going one step further beyond the building codes. Dr. Lackey reportedly paid 15 to 20% more to build his home than other homes in the area, an excellent example of an investment in mitigation that has paid off. This example of a strong and resilient home can be translated into creating strong and resilient communities by taking small and incremental steps to invest in mitigating the effects of disasters on health. We need to build systems that allow us to accurately track the long-term health effects of disasters and to understand whether our responses are effectively mitigating those effects. The health response of disaster is about more than just the immediate period of acute health issues, and we can do better. I'm a health services researcher and a nurse scientist focusing on disasters, and I invite any of you with complementary expertise to contact me. Thank you very much for having me today, and I'd welcome any questions.
Thank you, Sue-Ann. That was very interesting. I think it's often overlooked, as you mentioned at the beginning of the presentation, the long-term effects on health and vulnerable populations of disasters. Once the cameras go away and once the media coverage declines, we often forget about the long-term effects. So thank you for that presentation. I found it to be very, very interesting and informative. We're now in the part of the presentation where we'd like to take questions from the remote audience. And there's two ways you can send in questions, though the preferable way is for you to actually ask a question directly to Sue-Ann, and I can unmute your microphone and you can ask a question directly. And there's a little hand icon that you can click, which will essentially virtually raise your hand, and I can see it, and then I can go ahead and unmute your microphone for you to ask a question directly. If you're feeling a bit shy and don't want to do that, you can also send a question in by the chat feature, and I can read it off, and we can get your questions answered that way. So without further ado, let's go ahead and open this up to questions. All right, so we have two brave people here. So I'm going to go ahead and call on Frank Summers. Frank, I'm going to unmute your microphone here. Just give me 1 second. Okay, are you there, Frank?
Yes. All right.
Okay.
Thank you, Doctor. Thanks so much, Dr. Bell. Very interesting report of your research. I wonder whether you had a chance to look at incidence of suicide, a mental health indicator following disaster, and B, whether you had any opportunities to study non-US populations. There's lots of global disasters happening, and whether those findings would bear out what you're finding in the US samples. Thank you.
So thank you so much. Those are two great questions. No, I do not specifically study mental health, so I have not looked at that, but I do think it's an important area that data probably does exist for that question to be answered. So a great question and probably a great avenue of study. And in terms of looking at non-US populations, one of my biggest challenges is finding data that I can make a connection. And so I've found that in the US through some of the data sets that I've mentioned. And I actually have probably a lifetime of research in using some of those data sets that I'm currently using. But I think that there's probably a wealth of data out there. I don't know how much it would be aggregate data, which can be, more of a challenge in terms of thinking about the ecological fallacy. So I think that is important to be studied, but I would probably love to connect with an international population to explore those uses of that data or finding the correct data set to answer some of these questions. Thank you.
Thanks, Sue-Ann. So we have a couple other participants with their hands raised. So I'm going to go ahead and unmute Sarah Newell's microphone here. And I just want to apologize in advance if I mispronounce anyone's name or last name. So, okay, Sarah, I'm going to unmute you here. Go ahead, Sarah.
Thank you. And thanks, Dr. Bell, for your talk. Your last response leads into my question related to the data sets that you're using. I'm a Canadian researcher, and I was just curious about whether you were using publicly available data or privately available, like through permissions, and the impacts of some of these publicly available data versus data where you need more specific permission.
Well, so I have used a variety. So HRS data, as I mentioned, the Health and Retirement Study is publicly available. The FEMA data, FEMA maintains a website. It's openfema.gov, and they have a number of data sets on their website. But I will be honest, I have found many of them of, not analyzable quality, I guess. I also use SEER data, which some of that is publicly available. And then, Medicare and Medicaid data is a wealth of information. The majority of older adults in America are on some version of Medicare. So when I initially got the data set to use Medicare data, I think we had over 11 million people in that data set. But it's really hard to obtain a complicated data use agreement, and it is inexpensive. I'm sorry, it is expensive, not inexpensive. So that's a challenge for many researchers, is that, we need funding to do our work in order to use data sets like this. So one of those challenges is to either find funding that will support use of these data sets, or find publicly available data sets. And I think that's, sort of a trade-off you have to consider, or you kind of have to do both of those things at the same time. Thank you.
Okay, we have another question from the remote audience. Craig Oranmore-Brown. Craig, I'm going to unmute your microphone here.
Hi, Craig. Nice to hear from you.
Yeah, nice to hear from you. Thanks for your fantastic presentation. It was really well done, and you've been doing a fantastic amount of research. This is really helpful for the international community. Congratulations.
Thank you.
My question is, looking at the responses from your research, there's clearly a big impact, not only in the short term, but going into the longer term on the communities that suffer these disasters. And so the next thing that springs to my mind is, when you suggest that we need preparedness for disasters, from your experience and your research, what do you think would be the way to prepare for these things in such a way that these communities would be more resilient?
Well, that's the million-dollar question,
Yes.
for sure, and probably one that multiple people could devote their lives to. I know that there's a number of factors in thinking about resilience in general. Community resilience is a topic that, it's the idea of a community to withstand or bounce back from an acute shock. And that's just a short definition for it. But in actuality, there's not even a consensus definition for what community resilience is. And I think that goes back to one of these fundamental problems in disasters and in thinking about all hazards preparedness, is that every disaster is different and every community is different. So a lot of the response and the resilience measures will be specific to that community or that region and need to spring out of that sort of whole community in order to be effective. Thank you.
Yeah.
So, sorry about that, Craig. I muted your microphone. Did you have a follow-up question or comment?
No, I was just saying that it's a fantastic opportunity for research going forward for those of you in the field to look at different environments, different disasters, and how various tools have been successful in mitigating some of these crises.
Excellent point.
All right, I'm going to look through here. I don't see too many other hands raised here. In fact, that may be the last one, but I have one question that came in through the chat here. So I'm going to go ahead and read this. It says, on the slide where you showed a significant increase in hospitalization in Alabama, there also appeared to be a decrease in the last state, which I think may have been Georgia. So the first part of the question is, was that indeed the case that there was a state that had a decrease?
So, right, we looked at, I believe, 3 other states, Mississippi, Tennessee, and Georgia. And in those states, hospitalizations did not significantly increase. And there's a number of reasons that I think that I can answer that. And as I mentioned, Alabama had a 9% increase, which if you think about why did Alabama have a 9% increase? Well, Mississippi, Tennessee, and Georgia were included in our analysis, but they actually had a much smaller impact from the superstorms, whereas Alabama recorded the highest number of tornadoes and the highest storm impact. So I think that is our sort of translation to that finding, is that I guess kind of the obvious lesser storm impact would mean lesser hospitalizations.
Okay, we have a couple other questions that came in here, or a comment. There's a comment here that I think it's in reference to the discussion about data being available internationally. It's pointed out that WHO might be a source for some data sets that you could use.
Thank you. Good point.
I have a question here from Tara asking, have we found a gold standard household emergency preparedness instrument yet?
So I think that's a great question, but probably not one that I'm exactly the right person to answer. I know that there's been a lot of research out there about it, and in fact, research that seems to be sort of never ending as that's sort of continually perfected. Thank you.
Okay, I think that might be the end of the questions here. Well, again, I want to thank you, Sue-Ann, for taking the time to do this. As with all the other presenters, this is volunteer, and we know you're busy with your teaching and research commitments, so we do appreciate you taking the time to do this for us. And we really appreciate everyone in the audience here, because I know for some of you it's midday, some people might be early in the morning, others it might be in the evening. To support our webinar series. It's actually been growing over the past year and a half, so it's really exciting to see that more and more people are finding out about it and participating. We have a few more comments here, just a number of people thanking you, Sue-Ann. So again, I guess we'll echo that. I'm thanking you on behalf of the association. Did you have any final comments you wanted to make before we wrap things up?
I don't think so, but thank you very much for the opportunity. And I'd encourage anyone with any other questions or comments to contact me at the contact information on the screen. And I look forward to seeing many of you and meeting many of you in Australia.
Thanks for the plug for the Congress there. And as I mentioned at the beginning, we are recording this and we'll do probably a little brief editing to it, upload it to the website, and I'll send that out to the registration list by email. And I can put Sue Ann's contact info in there if you want to touch base with her directly. So thank you again, everyone, for supporting the webinar series, and have a great day, evening, morning, or wherever you may be. Thank you.
Thanks, Sue Ann.
Thank you.